Before I get into it, I was thinking just before I come up, I have a slightly more cynical colleague in the centre who has described partnership as suppressed mutual loathing in search of funding. I hope this is a more optimistic version of partnership approaches in terms of addressing inequalities. She's smiling up the back. I won't mention who it is. Okay. Pete touched upon the Christie Commission, and I'm going to give you two examples of work that the Centre has been involved in. One of them is still ongoing. In relation to partnership approaches to developing an inequalities approach. And I think to a certain extent these two approaches, one at a local level and one at a system-wide level, I think they do tick a lot of the boxes. Pete mentioned the Christie report, and I think they do tick a lot of the boxes in terms of developing a bottom-up approach, involving communities, and a kind of integrated partnership approach to delivery. These are the two areas I'm going to talk about. The Healthy Wealthy Children project, which is an NHS partnership approach to addressing child poverty. Quite an extensive project with quite a lot of committed, and I really genuinely mean this, committed partners involved in this, from the voluntary sector, Child Poverty Action Group, Scottish Poverty Information Unit, NHS, local authority in the centre. So there really was a lot of commitment to this partnership approach, to this NHS-led partnership approach to addressing child poverty. And the second area I want to talk about is some work that my colleague Chris Harkins was involved in, the Equally Well test site down in Govan Hill in South East Glasgow around participatory budgeting. Before I go on to that, I'd like to just go back to the work that my predecessor, Pauline Craig, was involved in. And I've titled this A Culture of Possibilities because I think it's important to give these two areas of work I'm going to talk about some context, because it didn't happen in isolation. There was a lot of work went on in the run-up to that. Not just within the centre, I have to say, but other colleagues too, working at a health board area. But one of the particular areas of work that the centre was involved in over that 5 years period was work around trying to develop inequalities thinking and linking research, policy and practice. And for those interested in it, there's a briefing paper you can read later on. I'm sure that's up at the publications desk. But in essence, that work was about trying to support partnership inequalities thinking around approaches in terms of either targeting the worst off or reducing health gaps. And I'll give you a list of some of the areas of work that Pauline was involved in relation to this. So I think this was quite an important background setting for some other stuff I'm going to talk about. And the work wasn't just focusing on NHS, Greater Glasgow and Clyde, it was beyond, such as doing some work with young people in Alcohol and Fife and colleagues up in Dundee around a CHP action plan and trying to get an equity focus within that action plan. Before I move on, just want to kind of step back and reflect on some of the kind of learning that came from that work. So there was a realisation. It's funny because in my previous incarnation, I was part of that workforce that was engaged in that down in North East Glasgow in relation to some work that was getting done in terms of mental health and early years. So it's quite strange coming at it from this point rather than being the stakeholder on the other side of that. But I was involved in that. There was a lot of commitment, a lot of engagement in terms of looking at how we relate in an inequalities perspective in terms of what we do, why we do it and how we do it. And also trying to link action on inequalities with equality issues, and I'll come on to that later on in terms of the Child Poverty Project. And also the need, because bearing in mind, especially in Glasgow in 2006, we were starting to see the emergence of community health partnerships, building an inequalities discourse within the planning process from the start. And it's quite interesting that from a kind of policy dimension, there's an awful lot of attention right now in terms of health inequalities with the task force being reconvened, the Scottish Parliament committees looking at health inequalities, and the Audit Scotland report, because I think, and Bruce touched upon this earlier on today, that there's still a capacity issue for not just the public health sector workforce, but beyond in terms of engaging with it, using the data, analysing it, interpreting it, and implementing it in terms of day-to-day service delivery. And along came a new possibility, and I suppose I came along at the same time as this, the Healthy Wealthy Children project. It was launched in October 2010 down in St Andrews in the Square by Linda de Castiga. I've mentioned already some of the partners that were involved in it. And it was a 15-month project funded by the Scottish Government Welfare Division. And these were the three areas that the centre was involved in terms of looking at evaluation. So we focused on the impact on service users, how models were developing at a local CHP level, and the effectiveness of these models, and the impact on practice, policy and strategy. The impact on practice was primarily focused on looking at midwives and health visitors across the NHS board level. I thought it'd be useful just to give you, for people that are not familiar with the project, just to give you a kind of an overview of the delivery of the project and how it was delivered. So you'd have a financial inquiry with the pregnant woman or family member, and if they fitted the referral criteria, which I'll talk about in a minute, they'd be referred on to the commissioned money advice service across NHS Greater Glasgow and Clyde. And they'd be offered advice, and if necessary, onward referral to additional services. Health improvement staff and money advice staff are very, very important in terms of the capacity building of this project. Just to give an example, we're talking 14 to 15,000 deliveries every year across the board, a midwifery and health visiting workforce of 1,200 staff. So it's quite a sizable workforce you're talking about. So health improvement and money advice were very important, supported by colleagues at Corporate Inequalities team at the board in terms of the development, the implementation and the reporting arrangements that were set up for the project. This is the referral criteria. It's quite a broad referral criteria. A lot of debate, especially around the household income. We can maybe talk about that later, but I think that was the right, Pauline's nodding, the right choice in terms of the criteria because it's quite high. But that upper threshold was upper threshold at the time in relation to people that were eligible for tax credits. So it's a very broad criteria that we adopted, and it'd be interesting to get people's thoughts on that in terms of the whole debate about universality, proportionality and targeting. I've kind of pinched this from Mike Kelly's work down in Nice with Hilary Graham. It's just to give an idea of the project in relation to how you can develop this response to addressing the social determinants of health. I've used the welfare system as an example. I'll come on and talk about the welfare system later on, but I think the project's been a really good example in terms of linking equality issues in terms of gender, lone parenthood, ethnicity, poverty, either being in poverty or at risk, with action on inequalities. And by action, I mean things like new delivery of money advice services, where you were seeing money advice services. For the first time, some of them are moving into NHS clinics to deliver the services. I hadn't done that before with young families. Offering telephone appointments or visiting people at home. Changes in the delivery in terms of the midwives and the health visitors. I mean, this project was competing with heat targets, big caseloads, etc. In some instances, with just workforces. So there was a lot of competing drivers in terms of trying to get this implemented. And I think in terms of that, and also individual expectations, there's an emerging discourse about the skivers and the strivers. And what I think was quite important about this project was that over the 15-month period, we had 2,500 referrals. And out of that, 1 in 4 had some financial gain. Now that annual gain came to just over 2.5 million. And I suspect a lot of those families wouldn't have been accessing that money that they're entitled to if we'd kept the system as it was. So I think that's quite an important point in terms of the importance of partnership, in terms of changing delivery, but also in terms of changing people's expectations in relation to what they're entitled to. Not only was there good client average gain, can I just say that average annual gain is based on citizens' advice. I'm not going into the technicalities of that, but I can explain later on. And another positive outcome was also onward support onto other services in terms of childcare, employability. So it was a knock-on effect beyond just offering people advice. And there was good reach in terms of areas where there was larger concentrations of minority ethnic populations and also lone parents. 6 out of 10 referrals were lone parents, a group that are known to be at risk of poverty. In terms of the referral, the 2,500 referrals, 8 out of 10 were from midwives and health visitors. So it was a real significant early years buy-in to this project. I want to move on from healthy, wealthy children to come back down to the Government Hill participatory budgeting, which is part of an ongoing range of work, test site work as part of the Equally Well project. I don't know if many people are familiar with participatory budgeting, but it was first kind of noted in Brazil late 1980s with the demise of the military dictatorship. And they took it quite significantly in Brazil, in this city called Porto Alegre, where there was significant investment in terms of getting communities involved in this democratic process of being involved in the decision making in terms of how public money is spent. So in Govan Hill, between 2010 and 2011, a PB pilot was set up. It was very small compared to what was happening in Brazil. £200,000 of Equally Well funds was used to test out this pilot. And the main kind of driver was GOCA, the Govan Hill Community Action Group, 20 members from different community voluntary sector groups across the area. It was facilitated, the process was facilitated by Oxfam UK, and that was quite important, and the evaluation was carried out by the centre. And it was also endorsed by the local community planning partnership. And this is how they spent the money. It's quite interesting, people who are familiar with the Govan Hill Baths Trust, that's quite a contested political issue within the city, so it'd be interesting to see what people's thoughts are, but this is how they decided to spend the money. What were some of the lessons from this project? Well, I think for all concerned, it was seen as positive. An independent facilitation from Oxfam was really considered quite important. And the members reported feeling a sense of, embracing responsibility and empowerment. It's funny actually listening to the films about the Lottery Award that Bruce's films this during lunch break about the anxiety of suddenly having all this money and being responsible for it, because there was an element of that within in the project. But notwithstanding that, there was this sense that money was being used wisely, strategically, people were prioritising people ahead of place, and they were bringing some fresh thinking to the table. But there were also some challenges in terms of time pressures, community representation, in the sense that maybe there could have been, looking back, an opportunity for younger people to be involved in the process. And also this idea that this public sector staff had this desire for community professionalism, i.e. people who behaved, looked and talked like us. So I just want to, before finishing up, I just want to touch upon some new areas of what the Centre's getting involved in. The Healthy Wealthy Children project is still ongoing, and we're involved in a light touch evaluation where we're looking at how the project's being embedded across the NHS. I think as things stand, we've now got 4,000 referrals since it was launched in October 2010. We're now moving into new work with colleagues from the voluntary sector, looking at lone parents moving into work as part of the welfare reforms. We've started to develop some thinking and some work around the changing nature of work. Work is changing significantly, not just in Scotland, but beyond, in terms of more people are working self-employed, working at home. There's a rise in temporary work. And the idea of a job for life is gone for a lot of young people growing up with that concept. And also the rise of in-work poverty. And we're interested at the Centre in asking questions about how does this change in the labour market impact on health. New economies is not, my involvement in this is, or the Centre's involvement in this is not new. This is something that the Centre's been grappling with for quite a while. And I would urge you to read the 2008 report, because it was just before the financial crisis that my colleague Andrew Lyon and Pete Seaman produced. And that's asking Glasgow citizens about their view of the economy as it is now and how they'd like to see it in the future. And it's actually quite interesting reading. I'm not going to say too much about these are speakers that were involved in the seminar series, because I know that Carol's going to be talking about that later on. But there is a general view within the Centre that is something we want to look at, about how the economy is working or not. And we know that others, such as Oxfam, are quite actually involved in that. I just want to conclude by saying we're not naive to what's going on in the wider context. I mean, somebody once said you can see the changes in the NHS from outer space. I would say you could see the same with the welfare reforms. The welfare reforms in the UK are significant, probably the biggest since the last 60 years. We've also got constrained public spend, the changing nature of work, household costs are rising. So I'd like to just finish off by saying, with that in mind, how can we extend doing things differently, such as PB and the HWC project, in terms of some of these challenges that are ahead? Thank you very much.